Aloha and welcome to this evening's inaugural program of Conversations at HMA. I am Mark Alexander, Executive Director of the Hawaii Medical Association, and it is my pleasure to welcome you to this evening's program. This program, Conversations at HMA, will feature conversations with physicians and other thought leaders in the healthcare arena. Tonight, we are pleased to have with us for our inaugural presentation, Dr. Kelley Withy. The format for tonight will be pretty straightforward. We're going to start with about a 15-minute presentation by Dr. Withy, and then you'll notice on the Zoom webinar feature that we have the Q&A function activated, and we invite you to submit questions, comments, suggestions, and ideas around how to address the physician shortage. And you can address these questions, these ideas throughout the program. We will be compiling them. We ask that you type in your questions, your comments, suggestions, and ideas. We have some people here in the room, and we ask them to please write your ideas, your questions, suggestions on the index cards and give them to Mark Conching so they can be entered into the Q&A function as well. We will run this program for approximately 1 hour because we really want to respect people's time. Where will we go from here? We will compile all of the various questions and comments, suggestions, and ideas that come in. We've already received a good number via email. We'll put them together and we will share them with participants. After the legislative session, which ends May 4th, during the summer, HMA will be convening a group of primarily physicians and other community healthcare leaders to discuss and develop an implementation action plan to address the shortage of physicians. We believe that the timing is right for this, given the longitudinal research by Dr. Withy on the shortage, the 2022 Access to Care report by Community First, and what we hope will be an impactful legislative session. We want to hear from you. You can always email us at info@hawaiimedicalassociation.org or contact us via our website. At this time, it is my pleasure to introduce Dr. Kelley Withy. She is Professor of Family Medicine and Community Health at the University of Hawaii John A. Burns School of Medicine and Director of the Hawaii Pacific Basin Area Health Education Center, AHEC. Her research focuses on health workforce assessment, health careers development, rural health, telehealth, and substance use prevention. Dr. Withy has over 100 presentations, publications, and funded grants for projects on predoctoral training, rural health disparities, health careers recruitment, provider retention, cultural factors in medicine, distance learning methods, telehealth, cultural factors in medicine, opioid prevention and treatment, community health education. Dr. Withy is the primary physician workforce researcher in Hawaii and has developed the only statewide database of supply and demand for physician services, as well as a statewide telehealth network called Hawaii U Telehealth. She has designed programs for all years of schooling that are being employed with more than 4,000 students a year. Without further ado, we welcome Dr. Kelley Withy.
Well, thank you for inviting me and thank you for having me here. And I'm afraid I'm going to tell people what they already know. We have a shortage of over 700 physicians when compared to a population such as ours on the continent. But I'll break it down a little more. Is the PowerPoint up for them? Great. Okay, so we have 11,325 licensed physicians, both DO and MD combined. And you can go on from that slide. Yeah. So that is up 733 from last year, but you can see in the red, it's only 105 full-time equivalents. So we only have 105 more full-time workers in physician workers than we did last year, even though we got 733 new licensees. So there's an issue there, but one thing we did see this year, and this was 105 is a great number. I'm not complaining about the 105. You'll see in a graph later on, if we continue at the 105, we could get to where we need to be by 2030. We don't usually have 105 every year. So that's our net gain, and that is wonderful. What was interesting this year is that there was a lot of movement both into and out of practices. So during COVID, a lot of people closed their practice down. Some people came back into it, but then some retired after coming back. But there are a lot more locums than there used to be. And I think this is an impact of COVID. We found that at least 60 people retired, 7 passed away, 84, at least 84 moved away, and 212 decreased their time, which indicates to me that they're probably going to retire in the future, not too far away. But 90 increased their time, probably a COVID effect or after taking time off effect. And then 39 reopened their practice after closing it for COVID. And the most beautiful thing is we have 200 new doctors, and many of them were our medical school graduates. So we're very hopeful, very thankful for that. Go ahead to the next one. We are all getting older, but for once, we're getting younger. So now our average age is 53.3. Last year it was 54.6. So as a physician population, we are a little younger than we used to be. But 21% of our doctors are still already over the traditional retirement age for workers in the US. Last year it was 22%, so we are decreasing in that percentage. Women, we have more and more women in the physician workforce every year. And for the first time, we've been able to quantify our ethnic composition, and you will see that it is nowhere near representing our ethnic mix of the population, but we are going to track this, and we're hoping for more of a mix that looks like our population. Can you go to the next one, please? This is what our numbers look like. The orangish is the demand model, and it was down last year because we got a new demand model, but we have now figured it out. And so that line is actually pretty straight. And then the green is where our physician population has gone. And in many respects, the recent low is COVID related. But the low in the 2014-2015 time period, people were retiring and we weren't importing as many or training as many. And then we had some good years during the recession. People didn't retire. So you can see there's a lot of factors that go into this. But this is what it's looked like since we've been tracking it. Can you go to the next one? And then people always ask me, what are the biggest shortages? And you can see them there. Well, the biggest shortage of all is primary care. But when you look at individual specialties, these are the ones that are the highest now. So we've recently started doing the child numbers, the child specialty numbers. So we don't know if we have all of the individuals listed who do those specialties. So we'll be following this carefully, but you can see the specialties that we need a lot of.
Some people are saying the slides are not advancing. I'm going to just share again.
Okay. Sorry, we're going to pause for a moment here.
And you can send out the slides if you want.
But we will be sharing the slides afterwards, but we'll see if we can make this work. I think so, maybe. Okay, thank you for your feedback, those online.
You want to try and advancing it and see if it works? Oh, okay.
Yes, it looks like it might be.
Is it working?
Okay.
Okay, so these are our estimates of statewide demand. The blue is last year. The black is this year. So even though we got those 105 full-time FTEs, we still have a shortage. Our demand grew more than our supply, so our overall shortage is estimated at 773. And you can see the biggest shortages on this island, on Oahu, followed by Hawaii County, Maui County, and Hawaii. The percentages improved a bit on Hawaii Island, stayed the same in Honolulu, very similar on Kauai, same on Maui. And it's a 22% shortage of physicians overall statewide. The next slide is the primary care shortages. And Hawaii Island has not done a nice job. They started a residency in family medicine, and they have now, they have met the demand for family physicians, not for pediatricians or internists, and they have no geriatricians, but they are doing a good job in the primary care area. Honolulu County has a big shortage. Kauai County tells me I am wrong, that they do have a shortage, so we're going back and looking at that more carefully. And then Maui has the most significant shortage by percentile. And overall, we're 15% short of primary care providers, physicians. You go to the next one. Okay, so this is the same slide as before, which you guys didn't see, but there's two projections there. So the orange is what has happened to our physician workforce over time. The gray is the demand model. The blue is what will happen if we just get our average 50 a year. But if we were to get 105 every year, we would be on that orange trajectory, and we wouldn't necessarily have our geographic needs met or all our specialty needs, but we would be approaching what we need. So that's an exciting concept, idea, hope for the future. Go ahead to the next one. So what are we actively doing now? We are trying to do a lot of things, and I'm glad you're all here because you're going to help us do all these things. So pathway activities. We have a lot of smart people in Hawaii, and a lot are changing to a health profession that they realized they wanted to go into health profession during COVID. So we have a lot of people interested in health careers, which is wonderful. And we have new programs in the high schools where students can graduate high school with they can be a medical assistant, a CNA, they can be a community health worker, they can be a dental aide, a phlebotomist, EMT, prepared for EMT training, I should say. They can do different allied health professions depending on the school through partnerships with DOE and Healthcare Association of Hawaii, HPH, and UH. Very exciting things happening in that arena. And then the idea is to allow them to skill up. So if they are a phlebotomist and they want to become a surge tech, maybe they can take classes while they're employed. And then let's say they say, heck, I want to be a surgeon. Great, let's help them get every step of the way. And I promise anybody in Hawaii who wants to go into health career, I will help, my office will help with all those pieces that you need. So anyone that wants to go into a health career, we are supporting. Expanding training. You probably have heard the med school and all the teaching sites on Oahu were full up. So what we're trying to do now is create teaching opportunities on neighboring islands, because there are a lot of folks there who want to go into health professions, and there's a lot of folks who want to teach. So I'm really happy for that. And the dean, outgoing dean, the incoming dean, everybody is on the same page about this. Even the Chan Zuckerberg initiative is funding 6 positions on Kauai, full ride scholarships, but you got to go back there. You're spending a third of your training on Kauai, and then you go back there when you're done for 4 years. So it's a year for your payback, and hopefully you'll get set up there and you'll stay there. So it's a 6-year grant. Hopefully they're going to have 24 new docs there in 10, who knows how many years, depending what specialty they are. So we're really excited about that opportunity. There's grants in for grants and requests from the legislature for more residency training, for more student training on all islands. And it's very often interprofessional. And if anyone's out there and has a home they'd love to donate on a neighboring island or even Oahu, we're looking for houses on each island for those students to go to. So it's just turnkey. You get on a plane, your friend that's over there already picks you up in the AHEC car, They go home, you take the car to the med student house. You know, it's a vision of mine, it's a hope. We are supporting recruitment. So we work with all the recruiters, and we have our webpage that advertises all open positions. So if you want a position, advertise, it's free. And we're getting a lot of hits on it. So we know that people are looking. But what we want to do is go to mainland conferences, big conferences like now I'm blanking. Well, American Academy of Family Physicians, American College of Physicians, and have a booth. And what we'll say is there'll be a beautiful booth, you know, surfing doctor, whatever. We'll say, hey, low pay, high cost of living. It's wonderful. Come on. And hopefully some
We'll
of
work
them
on your tagline.
Yeah, they won't hear the first part, but they will be interested, and we're hoping to get more interest in coming here. But what we really want to do is train enough here. We would have to double or triple the size of our medical school, our residency programs. We're working on it slowly, but surely we're working to that. So that would be our goal. And you're looking antsy, so let me just say, loan repayment and scholarships. There are some bills going through the legislature. We have a loan repayment program here. It's half federally funded, half locally funded. We've had 76 very happy individuals that are either in the process or have paid off loans through this program. And we have enough money right now to fund everybody who applies that works in primary care, OB. There's tons of different professions that can meet this. You have to work in a nonprofit in a health profession shortage area, and we can probably fund all of them right now because we have money from the state legislature and the feds. But the governor, you may have heard him talk about this 10 million this year, 20 million next year. I'm hoping that's going to be a fund that can go for anyone. So if you're a surgeon in Honolulu, or if you're an ID doctor on Big Island, you can get this when you cannot qualify for the federal requirements. So I'm hoping that that's what that's going to look like, because then we could fund anybody with loans, and that'd be very exciting. So we don't know exactly what that's going to look like, but there's promise, because then we would be the best state to come to, right? If everybody gets loan repayment, hey. And then the medical school's done a good job of getting scholarships. So I think it's about 40% of students have scholarships, more have some scholarship, but full rides. A lot of local organizations have contributed to make scholarships possible. Incentives. Okay, so one incentive is pre-sector tax credit. If you teach students, medical students, pharmacy students, or AP nurse practitioner students, you can get up to $5,000 off your taxes. Just off, not deduction. It's just credit. And so that's an incentive for teaching, and we're trying to expand it to specialists as well as primary care, because anyone who teaches primary care is necessary. We're trying to increase it to include psychiatry, because mental health is essential. And we're also trying to get PAs, nutritionists, and social workers included in the bill. So that is in the legislature right now. But that program is ongoing. And then there is some rural startup practice money. I know HMSA does a little bit, but you have to ask HMSA to get this. It's not publicized anywhere. Some other organizations do it, but the Hawaii State Rural Health Association is helping in rural areas. So if you're trying to start up a practice, ask HMSA, ask Hawaii State Rural Health Association. Continuing education, I don't think that's going to recruit anybody, but we have a lot of it. It's free, so that's good. Support groups, we are doing a mentoring program for new physicians that come to Hawaii. So if they don't know about Hawaii, we're trying to get them to know about the traditions, the customs, the history, because it's really beautiful. And we're hoping that might keep them invigorated, invested. And then telehealth, we love telehealth. Everybody knows how pretty much now since COVID. So let's see if we can maybe we've got some folks on the mainland who have their license and want to start dabbling in taking care of patients in Hawaii. And then we pull them back through telehealth, maybe. And then my dream is that we could get discount homes for physicians. This might be We just got news that there's some property on Maui. They're using 4 healthcare workers. You'd have to build the house, but you'd have a long lease time. So we're hoping we can find people who will help build houses. We're thinking of investors maybe helping physicians buy homes. The banks will loan doctors anything, but that's still a loan. It's not very low interest right now. So we're doing some salon dinners to try and figure out how to do this, talking with anyone who will help, because we'd like all our physicians to own a home, because if you own a home, you're more likely to stay. And then I want to hear from all of you, but first, I said this at our Workforce Summit last September, which is happening again this September 9th, so put that on your calendar. Hawaii Health Workforce Summit, September 9th, and free CME for everyone. Go ahead to the next slide, because we asked this of our 900 participants last year, and this is what they said. So they said the top things to do. No, you're good there. It doesn't all show, does it? But that's okay. I bet everybody can guess number 1. Minimize administrative burden. And so we're going to talk about that one as soon as I go through the list. But you'll recognize these other ones too, because they are not surprising. Increase local insurance reimbursement and salaries. Yes. Increase Medicare rates for Hawaii. Now we have our federal legislators working on this. They all know about it. And really the only way to do that without federal legislation that Alaska got to raise it to 1.5 times regular Medicare is to raise the gypsy. And so it won't be a big raise, but we're pushing for that and doing research for that. The next one is eliminate the general excise tax on healthcare. The governor supports this. There are bills going through the legislature that they're moving. And so that's great, because this, I think, would give us we figured, I believe it's a 9% increase in net pay because of the way it compounds itself. Improve electronic health records to expedite documentation and improve information flow. This is a big one. And this will take a lot of discussion because of all the barriers with electronic health records, all the updates, all the changes, everything. So we should probably have a group just on that from different organizations. Expand telehealth and ensure payment for it. So that's very important. Interprofessional models of care to share the workload. So as doctors, we take responsibility for doing everything. But if we can work with people to hand off some of these things, we really need to. Reimbursement for care outside of visits and services. Hey, the lawyers do it. Why don't the doctors do it? And there actually is a model that you can do store and forward consults and charge patients $25 they're using on the continent. And I sent you that information too, so you know about that.
I posted it on our member website.
I don't know if it's a good idea, but if you need some more revenue, it's one thing to do. Incentivize healthy patient behavior. Wouldn't that be nice? I mean, for a while, HMSA was giving free gym membership, but what if they said you got a lower premium if you quit smoking or if you decrease your BMI? And then rapid and efficient licensing and credentialing. Wouldn't that be nice? So I asked the doctors that were at the summit to tell me what we could do with what the most important things to do first were for the administrative burdens. Prior authorization. So I've been working with Nadine Tensal and HMSA, Steph Park, very nice. And we are working on this. So prior authorization. You might not know that, you know that Mike Gold came in and he made everything be prior auth, x-rays, everything. That's not the case anymore. There are not that many things that have to be pre-certified is what they call it. And it's on the website, what has to be and not, but it's hidden. It's very confusing. So the other good news, well, there's 2 other pieces of good news. Well, okay, there's 2 pieces of good news. That wasn't good news, but one is that there is one standard pre-certification form for 4 different insurances, and that the gold card is back. It's called a fast pass, like at Disneyland. So it's not the gold card anymore. but it's a fast pass. So if you don't over order things, you won't be forced to do all the pre-certification work. The good news on the first step I was talking about is we're working with Steph Park. We would like to make a large Excel table on their webpage. And I don't know if they're going to let us do this, but where you can click on the CPT code for what you want done, and it will tell you what you need to accompany your pre-certification form right there. That's what you need. Or it'll say nothing required, no pre-certification required. Because actually HMSA says they're getting a lot of pre-certs for things that don't require pre-certs. So we don't have to do it for everything anymore. Anyway, keep that in mind. And so the other things that they said was pharmacy. Is there some way to automate pharmacy? And we're working with that. So Roy Gu is a pharmacist that's working at the pharmacy school. He's also working for HMSA now. He already reached out. He wants to talk about how we can make the pharmacy, the prescribing process smoother. So we're hopeful on that. People said training of our staff on how to bill, or give us some medical assistants, some CNAs, give us some community health workers for our practice. So we're working on that. Quality metrics, make them easier, make them less of them. We're working on that. Telehealth, make it easier, make it common, pay for it. Yes, we know. Credentialing. So HMSA says they have their credentialing down to a much shorter period of time. I think she said 1 month, but licensure, they have very few people hired at DCCA right now. And so licensure is taking a long time. It was down to 1 day. One person had it done in 1 day once. That was 4 years ago. But now it's about 3 months. So we're trying to help with that, but it's very hard. Patient travel. The insurances pay for patient travel. They should coordinate patient travel. They should even pay for the airport taxi from the airport to the hospital. They don't always pay for that. So that's an area where it's going to need a little pushing. And then billing. And we need a whole committee for simplifying billing because there's a lot of questions that come up. So that is what we're doing right now. If you don't have my email, it's just my last name, withy@hawaii.edu. You can email me about any of these things. And I wanted to mention the 4 things, well, you have more that are going through the legislature. The 4 things I'm tracking: the general excise tax, the loan repayment funding, the preceptor tax credit, and, oh, I forgot to mention, increasing Medicaid rates in state is great, because what if our Medicaid paid more than Medicare, which paid more than private insurance? You know, whoa, wouldn't that be a flip? Anyway, so that is going well. And then on the federal level, Medicare, we talked about hopefully raising Medicare. Could there be a non-contiguous state designation such that we could all get the 10% Medicare bonus, which rural areas get right now? But you only get that on regular Medicare. You don't get that on Medicare managed care. What's it called? Medicare.
Advantage.
Advantage. Thank you. Medicare Advantage does not pay the 10% bonus to rural areas. I just found that out last week, and that makes me mad. But I guess, you know, it costs a lot anyway. So there's a lot of pieces floating around, and I think together we can really help things improve. Now, I did not say that the private insurers are going to raise your rates, because that would probably help a lot of this right there. But, you know, there's time. So that's all I've got. I see there's some questions and comments, and what do you think?
Yes, no, thank you very much, Dr. Withy, for that great overview. And again, we will be sharing the slides with our participants as well as your contact information. But let me go through a few questions that have come in as we get going in the Q&A and the sharing portion. One question at the top: do we know how many of the newly licensed doctors are actually locums? Maybe you should define locums. That came in as well.
Okay. We don't know that question, but we will ask this year, I think. That is an excellent question. How many of the Okay, well, we define locum, actually, people define locums themselves. They say I'm locums. And to me, that just means they're not permanently employed here. They're just doing a stint. So maybe what we'll do this year is we will specifically look at the new doctors and we will put, actually, we can pull that out. Yeah, we'll pull that out this year. I don't know the answer now, but we'll know it for next year.
All right, thank you. Another request is, could you speak a little bit more about how you come by the numbers? What exactly do they reflect? Licenses, special registration with insurance carriers?
So the numbers are bodies in offices. So we do a survey when you relicense and we say, are you actively practicing? Are you taking care of only military patients? And are you still in training? If they're only military or still in training, we don't count you. But if you're actively providing patient care to Hawaii patients, then we count you. Then every summer we call every office and we say, is Dr. Smith still there? Is Dr. Kaanoi still there working full time? Okay. And so we quantify how many hours each of the doctors are working. It's hard with like anesthesiologists, doctors who don't have an office, but we go to the groups then and we say, who are your regular doctors? And like the ED groups are very helpful and they say, this is who's full-time, this is who's part-time, and this is who's locums. So we are actually counting the bodies in office. Now, the demand model is more confusing because who knows what we really need. Dr. Pian just tonight told me he's been working 150% to make it, for a few years. And that's what a lot of people are doing. We're just working so hard to make it work here. But we are capping the hours at 40 because we don't want to say, oh, we don't need any more doctors because they're working so hard. We want to say, this is how many doctors the continent has with our same population. So what we did is we had a research company that does this for the federal government do a microsimulation model. So they used all the available data and they said, for a population of your ethnic, age, health, insurance mix for each county, if this population were on the continent, this is how many doctor services they would use of each kind. So that's what we're using to compare it to. It's far from perfect. And if we got 800 more doctors today, we couldn't hire them because there are not jobs for them. But if we were on the continent, that's what we would have. Does that make sense?
Well, it makes sense because as long as you're using a consistent methodology from year to year, then you can do comparisons and you can track it accordingly.
But there were some things we knew were completely wrong. So
Yeah.
Emergency doctors, we get all the tourists here. So on some islands, what we did is we say, well, 40% of the population on any one day of Oahu, I think it's Oahu, is tourists. So we increased the ED demand by that much on each island or in each county. And then psych, we knew was wrong. And so we had to assess how to do psych. And so we had done some research in the past because we are definitely short of psychiatrists. Anyway.
And one of the things that you do since you've been doing this now for what, about 10 years, this study, is you adjust every year. If there's some kind of error or change, you make a change in the following year.
Yeah, we try not to do that too much.
Right.
So, surgical specialties that are in demand. So there are just a few specialties that we adjust and it's all described in our report, who we adjust, and we keep those adjustments over time unless something changes drastically.
So another question that came in is, what are the data regarding time to second next available appointment?
Okay. We don't have that data. Time to next appointment is very indicative of the shortage. And there are some mainland companies that do that, but they don't do any research in Hawaii, unfortunately, because we're so small. We don't have very many large groups where they like to do that research. So the only way I could really do that is to do a secret shopper survey and call your office and say, hey, when could I get an appointment? And I'm not going to do that to the doctors. I promise not to do that to you. We don't know that. You probably know that because you could ask your front desk, how long does it take to get a new patient appointment? So maybe I should just ask you guys what that answer is. It's an area of research I hadn't thought about. What's next?
All right. Is there any chance, and this is going to bounce off of what you mentioned in terms of GET, is there any chance of eliminating the excise tax on medical services? This can improve the financial burden of clinical practice. We take care of many Medicare patients, and this brings in a lot of federal funds to the state.
Right.
I don't know if you have any further comment.
I've got my fingers and my toes crossed because people don't realize who pays that tax. The doctor's office pays the tax. You know, the doctor pays everybody first, pays the taxes, and then has 9% less than they would have for paying that tax. So, you know, I really hope so. And if we raise Medicaid rates, that would be great too.
Okay, well, this builds on that. This next question from Hilton Rayfield, actually. I usually don't use attribution, but in this case I will.
Hey,
The Healthcare Association of Hawaii has initiated legislation that would increase reimbursement for professional services for Medicaid recipients from 60% of Medicare to 100% of Medicare, effective January 1, 2023. If successful, how impactful will this be in terms of improving overall revenue, retention, and recruitment?
So 60% to 100% of Medicare, you know, you guys tell me, you're going to take Medicaid more? I think so. You know, I think it'll let people, you know, people want to take Medicaid, but if you just can't get your office solvent, you can't. And so this will at least bring it up to Medicare, which is not a great rate. And some people have told me that our private insurers actually pay less than Medicare. So, you know, it can't hurt. And thank you so much for doing that, Hilton.
And this is a comment. It's seeming that the increase in salary would be something that would be the biggest asset in keeping physicians here. It's hard to compete with the mainland when there is less work, as you said, and this is something that's spoken about for decades, but the focus always seems to be punted elsewhere.
I always hear if we raise physician salaries, we'll have to raise the pay, the cost of the healthcare. I don't know what to say, but we need physicians to provide healthcare. So I think we're going to have to bite the bullet and actually raise premiums.
Many of the solutions being addressed are for immediate improvements for either administrative tasks or patient-centered care. I would like to keep pressure on JABSON that there is not enough students from the outer islands to be future doctors who most likely return to the neighbor islands. I would like to see who is on the admission committee, which is not made public, and it would seem the neighbor islands would be better served by having representatives on the admission committee.
I don't know who's on the admissions committee either, but I'm really excited about what JABSON is doing for neighbor island training. So we want every island to have cohorts from that island who train on that island for their first 2 years at least, and part of their third year, and then fourth year, you know, wherever they want to get other experiences, because those are the people that know that community best. And so I will help anybody from neighboring islands get into medical school. In fact, they won't let me be on the admissions committee because they know I help people. They won't even let me interview in-state people because they know I'm helping everybody get in. So they only let me interview the friends from the continent. I will help those students get in. And I make no bones about that, and obviously they do. Yeah. But the fact that we have initiatives like the Chan Zuckerberg that are specifically taking people from neighboring islands. So 2 of those students are from Kauai, 2 are from Maui, 2 are from Big Island, is my understanding. They'll all have to be on Kauai. But could we do that for Big Island, Maui, even Molokai and Lanai? I mean, you know, we have training on all the islands. Students can go to all the islands and train. So yes, it's very exciting. We're writing a grant for opening residency spots on Hawaii. We've got the idea for OB residency on Big Island. Maui would like that too. So yes, we need to do that. We need to train so those folks can be seen. We need to recruit those students so they can become those folks. We can't expand on Oahu anymore. Tapped out. This is how we have to do it. And the deans, both outgoing and incoming, they know it and they love it and they embrace it.
Thank you.
Very happy about that.
Yes. Another comment came in, question. Many people leave Hawaii because the spouse has family on the mainland. Get doctors to marry local spouses.
Yes.
I'm just the delivery, the messenger here. Okay. So,
No, we should have the
all right.
doctor dating service.
okay, there we go. All right. Okay, HMA is not likely to embark on that program. But, okay, but thank you very much. Can we buy military contracts, medical school boards?
Military contracts, let's see. We do have VA agreements so that we share some VA teaching. Military contracts, tell us more about military contracts. Okay, yeah, we can wait for
Yeah,
that.
we can discuss that offline then.
Do you know what they mean?
Well, he's right here.
Oh, tell us what
I
you
mean, if
mean.
you want to.
So the military has loans that they give to medical students. The loans are already pre-existing. Could we buy the loan and buy the person who goes with the loan and have them fulfill their requirements here?
I doubt it. The military is very prescribed with their requirements. And actually, the VA is now doing a loan repayment program too, because they need people so badly. But I don't know. I don't know, but I doubt it.
Thank you. And then a comment, I think this is for another venue. Physicians cannot practice acupuncture in Hawaii without an acupuncture license. Hawaii Medical Board and Hawaii Acupuncture Board need to fix this. Can HMA share any updates? There is legislation that's being discussed right now. It's still in process. We'll probably know by tomorrow whether that bill is going to move forward or not. But we can discuss more offline. Another question that came in, what are the insurance carriers doing to fill their specialty gap needs? To be determined. Hawaii IPA has a clinic on Maui for specialists and primary care doctors to see patients, and in fact could help take new doctors moving to Maui to get started with building a practice without the expense of starting up a private practice. This model would work everywhere in Hawaii.
That would be nice. People have asked for practice support. It's very important if you're starting a practice, and even if you have a practice, can we share the billing process, the outreach, the care coordination? Can we share a care coordinator for small practices? So some IPAs are looking into that and helping with that coordination, but that would be very helpful.
As a follow-up from a previous question, will you be working on increasing physician salaries and increasing premiums?
I voice my opinion about increased salaries and whenever I can, but I don't seem to have much power there.
All right, someone's following up. Some of these are anonymous, but again, I think it's important to share the questions and comments as they come in. Is it your opinion that the insurance carriers in the state don't care about the physician shortage, in particular, the specialty gap needs?
I don't know. I care about the physicians and the specialty gap needs, and I try to express them regularly. But I mean, the fact remains we have low pay and high cost of living, and it's not changing. Tell me your ideas about how to do that.
Yeah, I came in late, sorry. So, I mean, the main reason this shortage, and we emailed back and forth.
Dr. Lerner, we might not be able to hear you. The microphone's here, so yeah, so if you could.
Well, the general question, so what is the HMA doing to increase reimbursement to physicians? I mean,
Well,
the GET tax is a small thing.
Mhm.
I mean, what pressure can we put on HMSA specifically? Because they pay lower than everybody, and now they're paying lower than Medicare. So what can we do as a group? Because, I mean, literally people are going out of business for the reasons that you mentioned. And so, I mean, this is a body that should be able to figure some pressure.
Isn't that the fundamental question? He said, what can HMA do to raise reimbursements? So maybe if Medicaid reimbursements go up, then everything will go up. Maybe, I don't know. It's a tough one.
So, I mean, I've asked before, so what's the process through the Department of Health or DHS, I think it is, that regulates what we get from the insurance? Because it seems like some of the insurances pay higher than HMA and some don't. But there should be some minimum that we can get either by decree from the governor's office that bypasses either the Department of Health or HMA itself, because it doesn't make sense that they basically control what we make. And they shouldn't have
Yeah.
any power over what we do.
I don't think there is a regulatory regulation on it. I think it's capitalism. There is an insurance commissioner, and he makes sure that they have adequate networks.
So does the commissioner have any say over what monies go from the DHS to each plan? There's 4 or 5 different questions.
I don't know.
So Dr. Lerner, you weren't here at the beginning,
Right.
sorry, I just went, we're using a kind of a Q&A format. We're trying as much as possible to go through chat so that we have a record, but afterwards we can discuss some of these things at greater length. But
Yeah.
thank you.
And he has a good question, and
It
I
is.
don't know.
Another question that came, most private practices are having difficulty finding staff these days. There's high turnover and very few qualified applicants. We have to check on our own patients and do more with much less. Do you have any suggestions on how to get more medical assistance?
Yes, actually. So Hilton, if he's still on, thank you, because HAH, HPH, working together with DOE and UH is really invigorating this high school training. So there's career and technical education, and then they're building on this. So you actually can come out of high school with a degree. And I believe it's Roosevelt High School that they actually take the students completely out of their senior year, and they get a medical assistant training, and they graduate and they are medical assistants. Now this is small numbers. Can we increase this? We lost one of our medical assistant training programs from Hawaii. So we really need to expand this training everywhere.
You know, since you've been doing this work for so many years, and I ask you this question sometimes in different contexts. So looking at what's going on at the legislature right now and today's climate, what are your top 3 items on your wish list for action?
Definitely GET tax, Medicaid, the loan repayment, I hope continues. It'll continue anyway. I'll just have to beg people for money if the legislature doesn't give it, and then we just won't have as much. And then preceptor tax credit is near and dear to my heart. So I gave you 4, you asked for 3,
Okay.
sorry.
No, that's very good.
But you had another one. What else was on your list? You had one. I can't remember.
Oh, yeah. Right now with the legislative session, give your take on what's happening right now and the positives, the areas of concern. I know it's very early on. We haven't even hit first lateral. Well, we do tomorrow.
So they've been very receptive. What I've seen, very, when you come in the room and people are frowning at you, or they ask all kinds of questions about, nitpicky this and this and this, they're not doing that. They're very supportive and receptive, and I think it's going to be a great year. I worry next year we're not going to have any money. Now we have money. Next year, who knows? So it could be night and day.
So in terms of other kinds of actions, the physicians compact, what's your assessment of that possible impact on our physician shortage?
So tell me more. Would that be physicians being licensed in multiple states?
Compact that a
Well,
number of states have signed on to. It's still before us.
so we have shortages everywhere. So if you had your license and could go to any state you wanted to go to, would you come to Hawaii? That's my question. I think we still have to pay more and have the housing and the loan. We still have to recruit them. So it'd be nice because they could do telehealth, and maybe they could see how nice the patients are, and how could we then hook them in. But it would be easier for them to move here, but just as easy to move away. So we need to do something intrinsic to make this the very best place to practice, the best place to be.
Make a comment about telehealth. I don't do it because I can't do a physical exam, can't do tests on the patient. My own wound cultures. You can't really follow up that well, as opposed to direct. The thing it's useful in psychiatry, some of the fields you don't have to touch people, but often I've seen mistakes being made because when I see the patient in person, it's a lot different than when it showed up on a camera.
Yeah, so the comment was telehealth is good for especially visits where you don't have to touch someone because it's very hard. They're getting better, more sophisticated equipment, home monitoring, but it is still not as good as face-to-face. You can't hold someone's hand and reassure them. But is it going to work for specialist visits? Sometimes, sometimes not, yeah, I agree.
Hilton just observed and offered, he said he can provide information regarding the programs they are working on to train staff for medical offices. So we'll provide that linkage.
I think this is the biggest breakthrough in training is the partnerships that are working to get students employed when they leave high school. No downtime, they got a job, and then if they want to upskill and they want to do something else, great, but they've got a job. They're in healthcare. I think it's very exciting.
And someone commented when Hawaii Pacific Health pays for the medical assistant training, they go on to work for HPH. What about private practices?
Well, what if we could match private practices up with the local high school? Maybe Hilton knows how much it costs, and we could kind of calculate that. Maybe we could get it from the legislature. Maybe we could get it from the physician workforce fund that you guys pay. There's ways we can do it because HAH and HPH have groundbroken and started this. We could do this.
The incentives mentioned for teaching should also be extended for mentoring medical assistants during their clerkship in the doctor's office. We have supported the medical assistant schools as an effort to build up support staff for doctors.
Now that's interesting because we're trying to add specialists, social work, dietitians, and PAs, but do we have local medical assistant training programs? I think we only have one here on island. So email me about that. We're not going to do it this year, but it could happen in future years of this preceptor tax credit bill.
I hope this person won't mind me mentioning their name, Curtis Takamoto Gentile. Okay. Okay. And then Colleen Inouye offered, whoever asked about the HIPA Maui Specialty Clinic can email her at colleen@hawaiiipa.com. And again, we'll provide the contact information as well.
Hey, Colleen. Hey, Curtis.
Any other comments that you would like to make with some of the feedback that has come in right now?
I like the interest in training because that is how we're going to get where we need to be. We need more preceptors on neighboring islands. So if you want to precept medical students or nurse practitioners or pharmacists or social work, anyone, let me know. If you don't know how to connect to be a teacher, let me know. I can connect you up with people. Again, a plea for how we get student houses on each island and cars, if you want to donate cars, because we really want this turnkey idea. And so I tell people I'm not retiring, and I'm looking forward to retirement, but I'm not going to do it until we have houses on all the neighboring islands, at least the big three, for students to go to. But so I like the training. Let's get more training in high school. Let's really support students in the pipeline. Let's house them when they go to neighboring islands. Let's recruit more from neighboring islands into medical school. Let's make this work. So we have a lot of capacity here. The administrative simplification. I need help analyzing all the documents on HMSA's website because the answers are all in there. Do you need pre-cert for this or that? It's there. It's just so hard to find. I want to put it in a table. So I'm going to need help going through all of that and putting it in a table. And then they might just change it, or they might not let me put the table on their website. I don't know, but I'm hopeful because Steph Park is very supportive that we can do some things to make it easier. Billing, I said to her, well, if somebody loses their insurance and then gets it back a month later, why don't you just leave them in the practice they were in before? Because that practice didn't even know that they lost their insurance probably. And she said, oh, and she's going to look into that. So, that would help with billing. She said there are trainings that offices can get for how to bill, how to do pre-certs, that kind of thing. We just need to get that information out there. So there's all these pieces flying around. And if it would be great if we got that increased reimbursement, but I think it's going to take a lot of work from HMA, from everybody. But all these little pieces too can help if we can bring them all together. Not as fast or as sure, but I think we need to follow them all.
Couple other comments, Hilton, again, stated they have state and federal funds for scholarships for these various programs.
Right. Yeah.
So I think, as you say, the opportunity to collaborate and get the information out there, share it widely is certainly something that's going to move us all in a more positive direction. Someone asked, what role do you see for Project ECHO programs in Hawaii for improving patient access to specialty care?
So Project ECHO is a case-based distance learning program. And so the idea is that you can present anonymously, of course, patients, and you can learn how to take care of them from afar. And so you learn, everybody on the call learns how to take care of patients in different settings. And so it's very effective the world over at doing this. And so with our ECHO, we have a behavioral health ECHO, but not that many people are on neighboring islands. So we do ask the question, did it decrease need for travel? And I think about 20% of people said yes. So it can significantly impact knowledge and care. But again, it's hard to measure how much.
And then someone commented, don't put it in a table, integrate it into the order system of the EHR.
Oh, I love that. That's why we need that EHR
So you
committee.
didn't need to make that anonymous. That one was well-received comment. All right.
Yes. And by the way, so Steph Park wants you to have a Pizza Hut delivery system for your prior auths. So you can go to a website and you can, I don't know, put in the tracking number and you can say where it is. We got your order, it's being reviewed, it's been approved or it's been rejected, and this is what you do to appeal. So she wants the Pizza Hut tracking system, which will be the next step after we make the table and integrate it into your EHR. So you can find out where that form is, where that request is, or I suppose the patient could find out where their request is.
And a comment that came in, I appreciate the pre-frame. This is a commentary more than a question. The root of the shortage of physicians has been said over and over again as a financial problem of low reimbursement and high cost of living in Hawaii. My opinion is that there is a physician shortage everywhere, not only in Hawaii, because medicine has become just another job to make a good living. The medical profession is no longer the most respected profession that we want to enter to serve the people. I've been in medicine for 55 years and enjoy my work. If you're not happy and doing it to earn a living, soon you will find reasons to quit or retire early, which adds to the physician shortage problem.
That is absolutely true. And I'm afraid EHR is part of that because some people say they're just glorified secretaries, just typing all day long. I've been told I have to type when I'm in the patient room, and I said, I'm not going to look away from my patient. I'm sorry, I'm just not gonna. And so it takes longer to chart later. Students now are taught to chart while they're talking to somebody, to be asking all the questions, checking the boxes, to have the computer right there in front of them. But that is actually not helping our relationship at all. And it's frustrating doctors who didn't used to use it. I think the new generation, that it's just the way it is. So they're very comfortable. But if you used to be able to talk to a patient without something between the two of you, it's not what it used to be.
Well, Dr. Withy, we're going to give you a moment to close our session before I make some closing housekeeping remarks, and thank you.
Oh, okay. Well, if you don't know how to testify at the legislature, you can just go to Hawaii State Legislature. You can sign up and get you put in your password, you have your own identity, you can put in a bill number, and you can just email them and say, hey, I really support this, you need to do it. Just that much. It's that easy at the legislature. And you can do it when you can have a reminder. You can tell the legislature, the site, that you want to hear whenever a certain bill comes up. I think it's HB 82 is loan repayment, so things like that, or maybe it's SB 82. Testifying like on the GET bill, I think helps because they read every testimony before they vote. And so it's very helpful, and I would definitely do that because the general excise tax, it's going to be tough. It's money, and nobody in the legislature likes to give up our tax money, but I think it's important. Pipeline, if you want to mentor students, if you want to teach, if you want to retire and want a resident to work with you some to see if this is the right practice, let me know, because we can connect residents and practices, and we want to do that. Anything you want to support in this whole spectrum, let me know. We really need everybody in on this. And Workforce Summit, September 9th. I'll be there or be square.
Thank you very much, Dr. Kelley Withy. We really appreciate you joining us for our inaugural conversations at HMA. Thank you very much. And I want to thank everyone who was on the video for joining us this evening. Grateful to all of you for your participation and for your sharing, for spending some of your evening with us. You will hear from us by the end of March. We'll compile the comments that have been made and others that have been sent in by email and others that will be received doubtlessly after this evening's program. We thank those physicians who belong to HMA, and of course, we invite those who are not members of HMA to consider membership. And as always, simply mahalo and have a great evening. Good night.